This lecture discusses bronchiolitis. There is a con video that is on Blackboard. Make sure that you watch it. But bronchiolitis is oftentimes caused by respiratory syncytial virus. It can also be caused by metapneumovirus, parainfluenza virus, adenovirus, as well as mycoplasma. All of these are seasonal. The most vulnerable children are infants and toddlers. In addition, children who have chronic health conditions like bronchopulmonary dysplasia, that's what BPD stands for, cardiac disease, or other respiratory disorders, they have a high vulnerability for this. To diagnose it, you will be doing a nasal smear. So we use a little bit of saline, put a drop in the nair, and then we have a little apparatus and we suction out the mucus and we send that down to the lab. We'll get the results back usually within 12 hours. So why is bronchiolitis a big deal? Well, because these kids have their airways affected. They'll start out having URI symptoms where they have the clear running drainage from their nose, so they're congested, and they'll have a fever, but this isn't a 102 or 104 fever. It's going to be a low-grade fever. And then they have a cough. And the problem with the cough is it progressively worsens and it's very wet. When you listen to these children, you're going to hear adventitious sounds. They're going to have a lot of crackles, rhonchi, and wheezing all at one time. They'll be tachypnic. They may be hypoxic. And then you will see intercostal and subcostal retractions, and they may or may not have nasal flaring along with it. Because of the increased work of breathing, these babies are not going to want to eat. They're very irritable because they can't breathe. And because they're swallowing so much mucus, they may start vomiting. So bronchiolitis season, we're right in the height of it right now, is winter and spring. And the worst kids are going to be our 2-month-olds to 6-month-olds. And these are the kids you're going to see admitted to the hospital. Risk factors in the environment include being in daycare, being exposed to secondhand smoke, having older children at home because they're the ones who bring it home to these babies, and then infants who are not breastfed. Instead, they're bottle fed. 80% of kids have a bronchiolitis by the time they're 1 year of age, and most of us have had RSV bronchiolitis by the time we were 4 years old. So your nursing assessment includes taking the child's temperature, listening to their cough, getting their respiratory rate, determining if they're tachypnic, putting on a pulse ox, checking for cyanosis, and remember that the babies are going to have dusky mucous membranes, meaning you got to look at their oral mucosa in their lips because they're going to have cyanosis there. Are they retracting? And if so, how severe and exactly what kind of retractions are they having? Do they have rales, i.e. crackles? Are they wheezing? And then in your very young infants, you also want to keep an eye on them to see if they have apneic spells. Treatment is symptomatic. So bronchodilators have been the mainstay of treatment for those that we admit, but now this is controversial. So at some of your institutions, respiratory therapy may be coming by and giving albuterol nebulized, and others won't. And all we're going to do is give them oxygen, fluids, elevate the head of their bed, and suction. Last year was a particularly bad RSV season, and we had many infants in the ICU who were intubated. And they weren't just intubated for 24 hours. There were some of these kids were intubated for a week. Because the younger the infant, the more severe the symptoms. So you'll put your child on a cardiorespiratory monitor. You're going to administer oxygen. And as they get better, we're going to begin weaning them off. So they may start at 3, they go to 2.5, they go to 2, they go to 1, then they go to 0.75 like we discussed in Skills Lab. You want to admit these infants in a room that's very close to the nurse's station. When they're pulse ox alarm goes off, you don't want to be running down the hall, number one. And number two, you need to get in there if this kid is in distress. Make rounds on this child frequently. They are going to be in isolation. It's not going to be a quick trip, just running in, poking your head in and saying, oh, is that kid okay? No, you have got to put on your gown, gloves, and mask before entering. So practice that skill and be ready to go in and out of the room frequently. The diagnostic testing for bronchiolitis includes a chest x-ray and the nasopharyngeal swab. Some of these babies may get a CBC, but we really expect it to be normal. This is a viral infection. We'll also get their pulse ox. So as I already said, we're going to maintain hydration by administering IV fluids if they're not tolerating oral, giving antipyretics, elevating the head of the bed, monitoring them at a minimum of every 2 hours, but I think you should be in there every 30 minutes, especially if it's a new admit. RT can come in and give aerosolized bronchodilators. Typically, this is ordered every 4 hours, but if you notice that the child does clear up somewhat after treatment and 2 hours later, they're sounding worse, they're retracting more, their SATs are going down, then we'll have to call RT to come in and give them another treatment. Now, there's going to be a limit on how much we can give them for these nebs because of the tachycardia that occurs with the bronchodilators. If needed, the child will be intubated, and if we do that, then we will actually sedate them. So the isolation, this is an airborne as well as a contact transmission. And so the child is definitely on contact isolation. RSV can live on a surface up to 6 hours. For the other forms, the metapneumo and the adenovirus, those are more in droplet format, and that's why we'll be wearing a mask. Frequently suction the nose and the mouth of the child. They're going to hate it, they're going to cry, but it's necessary. They do have a potential for having a respiratory arrest, so monitor blood gases if they have been ordered, and this is usually with the kid being in ICU. One of the best things that we can do is prevent RSV, and we can do this by keeping at-risk kids away from crowds and sick people. Promote hand washing in all environments, schools, markets, hospitals, clinics, and then avoid secondhand smoke. We do have a vaccine available to prevent RSV, and it's called Synagis. It reduces the complications and certainly the admissions to the intensive care unit and needing intubation. But this vaccine is only indicated for preterm infants who were born at less than 29 weeks of gestation, or for kids less than 2 years of age who have chronic pulmonary conditions or congenital heart defects or some other immunocompromised condition. It's given IM once a month throughout the RSV season, so that's throughout winter and spring. That can be up to 6 injections. So this ends the lecture about bronchiolitis. Thanks for listening.